Respiratory system. We got a guy here sleeping. Um, Snoring, sleep apnea. We might have heard of these things. Definitely snoring, we've heard of that. That's like a kind of a pun, I guess. But the respiratory passages is kind of the beginning of this. So let's kind of click along, and here's a good picture to start with. Again, we're kind of thinking about the whole body when we look at these, because we're going to have a fetal pig test later that definitely some of these items would be on our list of things to know. So let's start at the upper respiratory tract. When we say upper respiratory tract, definitely it kind of makes sense. It's the nasal, the oral region. Really, if you just were to think about a line right here at the beginning of the trachea, anything that is above the trachea would be upper respiratory tract. And definitely a sore throat. We've all had to deal with that sometime. It would be right in there, in the region that we know of, the pharynx. Okay? So upper respiratory tract, nasal cavity, pharynx. The glottis is actually the circular ring that is right on top of the trachea. Our picture's kind of small, but you can kind of see like maybe a little line there. I always think of the epiglottis. Now, guys, they didn't label the epiglottis on this picture. It'll be labeled later, but it's right there under that red light. And the epiglottis covers the trachea when we swallow, during the swallow reflex. So if you remember the epiglottis, epi means around, and so it basically is around the glottis. When we look at the larynx, and quite honestly, the larynx is just right in the upper trachea. If you think about the Adam's apple, when you feel the front of the neck, that is the larynx. When you speak, if you put your fingers on that Adam's apple, you can feel it rattling. So the voice box, on a test question, just memorize, the voice box is called the larynx. And it's in the Adam's apple. The pharynx sounds so similar. And just think of the pharynx as the throat. Technically, if you look more specifically at anatomy, they divide the pharynx into 3 regions. And it didn't label it, but the nasopharynx, the oropharynx, and then the larynopharynx in the lower portion. But this picture doesn't show it. You might see some later that do. Here's our trachea, which is the windpipe. I always ask the relative position of the trachea versus the esophagus. The trachea is in front, so we say anterior to the esophagus. This picture, you can kind of see a little bit of esophagus behind it, behind the trachea. It's kind of difficult to see, but it's there. And we see the trachea bifurcate into here would be the right bronchus, and then the left bronchus. So when you think about the trachea, it's kind of like a upside down tree trunk. And we have a tree with a large branch, left and right. There's 2 large branches. And then just like a tree that's above ground, we have to have all these other smaller branches that go to the leaves. So the structure is very similar to a tree. The leaves would be the little air sacs, which we call the alveoli. Alveolar air sacs, or, an alveolus would be singular, alveoli is plural. So you'll see that written in different things. Anybody remember what kind of tissue that our air sacs are made of? It's epithelial, right? It was the stratified, or sorry, not stratified, but simple squamous. 1 layer thick and flat. So simple squamous epithelium. So, right now, guys, I'm getting over bronchitis, and I had a little bit of mucus in my small bronchioles. I could even feel it. Later on, we'll look at some diseases and like asthma and some other things. So the lower respiratory tract, I just kind of think of if it's in the trachea and lower. And quite honestly, as far as bacteria, we have a lot of bacteria in our mouth. Guys, there's over 6,000 different types in our mouth of bacteria. I mean, that's kind of crazy when you think about that. Definitely in our nose. So in this upper respiratory tract, it is normal to have bacteria, that is healthy bacteria, normal flora. It's there. But really, they consider, once you get down into the trachea, because of the mucus that moves upward with the ciliary flow, like this tissue has cilia on it that pushes the mucus upward, and it acts as a fly trap for bacteria, so you should not have any bacteria down into the bronchioles. They pretty much consider it sterile. And if you do have bacteria down there, you're going to have an infection. So here's our diaphragm, which is the muscle, the primary muscle of respiration. You can see where the cardiac, space is there. No heart is shown, but diaphragm is definitely there. And below the diaphragm, we'd have our digestive system. The book just ordered things: nose, pharynx, larynx, trachea, bronchus, bronchioles, alveoli. That's from out to in. Here's a zoomed in picture. So this is the one that has the nasopharynx labeled. So they put pharynx, nasopharynx first. We've got our oropharynx. If you think about going right, at the doctor's office, they say, stick your tongue out and say Well, it lowers the tongue, and then they can see in there to the back of the throat. And typically, when we think about getting a sore throat, it's just straight right behind, straightly posterior. You could have an infection that was up higher for sure, but usually it's right there, especially if you're a mouth breather. And also when we drink liquids, this is an area of the throat that has a lot of contact with, if you drink alcohol. Definitely, alcohol is an organic solvent, and it basically dissolves the cells in this region. They talk about double hit when you drink high concentration alcohol and smoke. This area is really, really affected with that. Anyway, so we see tonsils, and I've had different students talk about different things with tonsils, with tonsillar stones and just crazy things. A lot of times you can't find the tonsils very easily if people don't have problems with them. We see a soft palate here. The soft palate is the posterior portion of the, basically the roof of the mouth, and the hard palate is made of bone, so it's made of actually the maxilla, and then there's another bone here, which you'll learn in anatomy if you take it. We should remember the upper teeth are in the maxilla. Later we'll talk about bones, and that's a good thing to remember. The mandible is where the lower teeth are. And it's always interesting to look how big that tongue is. I mean, really, when we stick our tongue out, we kind of see like the tip. But the tongue is actually a pretty big muscle. It fills up really from the bottom of the jaw all the way up to the roof of the mouth. So it's kind of a big muscle. Other things on this picture: nares basically means nose. We see sinuses. There's the frontal sinus in the frontal bone. Here is the sphenoidal sinus in the sphenoid bone. We haven't talked about bones yet, but later you'll hear those words. We even see the first cervical vertebra, kind of how it's hooked up. And honestly, when you think about swallowing, you see the esophagus. There it is, posterior. It's the food pipe. It's going to the stomach, right? Memorize esophagus, food pipe. So it's going to be collapsed unless some sort of food, particles were going through it. They call it a bolus of food. Or drinking water. This is typically, it's a tube, and it does have muscle in it. Smooth muscle. Just like any of the vessels, or the trachea, or the pipes, I should just say pipes. The trachea has smooth muscle, and it can actually kind of tighten down and relax. We'll talk more about that later. But think about someone who has some older bony spurs of the cervical spine. Those spurs can actually go forward into the esophagus. You can have problems with swallowing. And we've all probably heard of reflux disorder. It talks about it later in the book. The esophagus is not meant for stomach acid. And definitely the worst thing to have happen is if you had someone vomit while they're sleeping and potentially some stomach acid go into the trachea. It's very, very bad, right? You don't want acid in your lungs. It will fry your lungs. Oh, so, our language here, it's saying hairs and mucus in the nose, filter air. Okay, sure. Again, the mucus is like a fly trap, and the mucus is always moving upward. Guys, out of our daily water loss, we actually lose about a third of our water through breathing, which is kind of crazy. Everybody, whenever I ask them, I say, how do we lose water? They'll say, we sweat and we pee, but we do, when we breathe, have to humidify the air. And we lose a third of our water that way. So that kind of tells you how much moistening of the air there actually is. Definitely, if you're in a dry environment, you can get nosebleeds easier. The moisture is just harder to keep moist in the nose and whatnot. People who live out in Arizona talk about that all the time. And we do have odor receptors later. We'll talk about that more so. It's actually above it's in the brain. And we have tear glands. Something interesting about our tears, as they're produced to help moisturize the eyes, they're produced out on the superior lateral portion of the eye, and they run down towards the nose and go into a nasolacrimal duct. So actually our tears are kind of like recycled. They go into the nasal cavity. So that's pretty neat. Again, our book isn't going to show that detail, but it's pretty neat. Tonsils are lymphatic tissues, so that's why people can have frequently tonsillitis and problems with their tonsils. They become enlarged when they're sensitized and things like that. And tonsillectomies used to be pretty common, but I don't hear a lot of people getting those these days. It just depends. So a lot of this language, guys, the pictures are always kind of the better way for the anatomy to look at things. This is just talking about mostly anatomy. Again, the larynx is the voice box, or the vocal cords are housed in it. And it says there are two mucosal folds that make up the vocal cords with an opening in the middle called the glottis. Again, I like to describe the glottis as the ring around the top of the trachea, and the epiglottis covers it. And here's a picture. Looking at this, I always think it looks like kind of like an alien. It's a weird picture. Think about, here's the base of the tongue. Okay, so this is just kind of FYI. We don't have to label this or anything, but you can see that the opening to the trachea right here. And so if someone was going to intubate, put a tube down into the trachea, that's where they're aiming, and they don't want to hit the vocal cords. They have to watch what they're doing, because you could affect the vocal cords if you ran into them. And if you think about like singers, when they say they can't sing because they have laryngitis, they're basically saying that they have a infection of their vocal cords, and it's affecting the way they can make their music, make their sounds. Because these things tighten and do all sorts of stuff when we talk or sing. Oh, they just showed us the same picture again. They do that a lot in this book. Basically, we've already talked about these structures, so we're going to kind of move on. Let's look at the idea of the trachea. We call it the windpipe. Like we mentioned before, I'm going to kind of scoot to something. There we go. take a look at this. This is an awesome, it's actually, guys, if you look at the bottom of it, it is the real specimen. And at the top, they just kind of showed us more of a diagram format. So this down here is actually a really nice slide of actual trachea, and we see the cilia, and this is zoomed in, I don't know. If this is enhanced and all that business. In the lab, we would never get it this big. The cilia look like very, very small. But the idea here is this is epithelial tissue. It's actually the one that's called pseudostratified. And the reason why it's called pseudostratified is because it's technically one layer thick, but it looks like it's several layers thick because of the way the nuclei kind of stagger. But the most important thing to think of is this is epithelial tissue with a lot of mucus. That's what these blue areas are. The mucus stains a different color. It's got, you know, basically these are called goblet cells. It's labeled up here. Goblet cells are one cell, little cells in the tissue that make mucus. And we all know what mucus is. And you can see that it's pushing the particles upward. These cilia do get burnt off if you smoke, and it takes a while, but then you don't have that benefit of mucus being pushed out. It kind of hangs out in the lungs. You start to get, you know, different problems, more infections. How big are the different pieces? Well, ultimately, here's an interesting number, 1 millimeter, right? The bronchi continue to branch until they are small bronchioles, about 1 millimeter in diameter. And the walls are thinner too. When you think about bronchitis, they're talking about these things having mucus and some sort of infection in those tubes. These are air tubes to get air into the lung or out of the lung. And ultimately, they go into these air sacs. There's going to be a good picture coming up of the air sacs. How many lobes do we have? This is a basic question sometimes. Since the heart is on the left, there's less room. So on the right, we have 3 lobes. On the left, we have 2. So there's 5 lobes total for a human. And again, the right side, it makes sense. There's a little more room, so we have 3 on the right. 3 on the right. The term lobule basically is a little lobe, and this is pretty detailed if you were a lung surgeon. They've got names for every one of them, but we don't need to worry about those details. We do need to know this term pleura. The pleura is really the wrapper around the whole lung that allows for the lungs to get bigger and smaller in the chest cavity and not rub, right? Normally we can breathe in real deep and we can breathe out real deep, and we don't have any grinding of tissue against each other. It's smooth, and the pleura is really what allows for that to happen. We'll see pictures as we move on. Guys, as far as the air sacs, and you know, I've never asked people how many million alveoli are in the lungs. You know, that's a lot, right? There's a lot of them. I do think it's interesting, instead of thinking about how many million of these there are, how big of a surface area there actually is. Like the thing says that there's 300 million that greatly increase the surface area. So somebody asked me, okay, how big is the surface area? And they've done some math, right? Some of the people that think about this stuff, they basically did some math, and they calculated it out that the average human has a tennis court worth of surface area for the exchange of gases. So we've all seen a tennis court, probably. It's kind of big, you know, so we're walking around with a tennis court inside our chest cavity to breathe. That's how much we need it. And definitely we do have extra capacity of lung ability because we're all sitting in the room resting kind of right now, and we know that we could go and try to run fast, and we would need more lung later if we're running faster to be able to keep up with the metabolism. It makes sense that blood capillaries would be around the air sacs. This is for the exchange of the gases. It's important that we know that we are one layer thick here. It's actually one layer thick of air sac and one layer thick of capillary. So technically you could say 2 layers is separating us, from air to blood. We do have surfactant, which helps open these airways. The chemical called a surfactant, basically I think of it as something that makes something slippery. It's not a soap, but it kind of acts slippery. So we have that in our lungs. And I will say, guys, it's interesting. If you think about the fetal pigs that we're going to see later, the fetal pigs have never had a breath of air. So if we take a little piece of lung out of the fetal pig and put it in a beaker, it will sink. If we go and we cut up a lung from a cat that has been breathing, because our cat lab, we have cats that have lived and they've had breaths of air for many years. So a lung that has been used after birth will inflate and open up and remain open the rest of that person's life. So if you cut it out, if you cut a little piece of lung out of something that's had a breath, it will float. And that is one way you can tell if a mother killed her baby. They will do that on an autopsy. The mom, she's pregnant, she goes home, has a baby, and the baby's stillborn. That's what she says. If they don't really trust her and they think something's funny, they'll open up the baby and cut a piece of lung out. And if the lung floats and the mom said that the baby was born dead, they're going to be asking more questions. Here, this is a nice kind of like the terminal end of the bronchiole, and we see it looks like grapes. You can see all of the capillary beds around the grapes. The air sacs are what I'm calling the grapes. And as far as histologically, like the tissue structures here, one air sac, when we look at it under the microscope, they look like, it's hard to tell, but this like circle here, this air sac, is actually made of maybe 10 or 15, 10 to 20 even, cells that are wrapped around in a circle. And it's 3-dimensional, so it's actually more cells than that. This is a 2-dimensional slice of a 3-dimensional object. But the big idea is it's one layer thick, simple squamous epithelium. And our capillary, they're also the same type of tissue, simple squamous epithelium. So this allows for very easy, this is the easiest type of tissue to get across. You can't make tissue any weaker. It just doesn't, you got to have something. You got to build something. We've got to hold blood into the capillaries. We don't want blood filling up into the air sacs, right? That's not going to work. So this is the weakest, the lungs really do hold up pretty good. If you think about living for 75 years and people who do smoke and we inhale, whatever cigarettes some people do, our lungs actually are really kind of resilient for what they have to do and how little, we're talking about sheets of paper type of thickness here. There's 300 million of these in your chest, so they're not very big. As far as the blood vessel, look at this. Pulmonary artery, it's blue. This was coming off of the right ventricle. The right side of the heart pumps blood to the lungs. So it's not gotten oxygen yet, and it's going to pick it up, and then it's going to go back. Pulmonary vein. Pulmonary vein, that's going up to the left atrium. So that's a nice little small picture of where this all occurs. This is where the gas exchange occurs. Okay, so we're going to talk about breathing in and out. Breathing is kind of they make it a little more complicated. Let's try to keep it simple. Inspiration, active process of breathing air in. We've all kind of get that idea. Expiration would be a passive process. In other words, you could say that to inhale, the diaphragm has to contract. Okay, now, I don't have a picture of the diaphragm up here. I moved it forward real quick just to kind of talk about it. So here's our picture. The one on the top is showing the diaphragm. If you think about it, it's got a concavity that's inferior. The concave area of the diaphragm is on the bottom. This is when the diaphragm is relaxed, because to make a relaxed muscle, it elongates. So this is a longer muscle when it's relaxed. And when it does contract, it says right here, diaphragm contracts and moves down. So basically, the muscle fibers of the diaphragm squeeze closer together, and that shortens the distance there, which causes it to go downward. And that would cause for increased total thoracic volume, right? This is the plunger. That's basically what the diaphragm is. It's a plunger. And the plunger is going to move down when it contracts. So this picture kind of showed it downward a little bit more. The total thoracic volume increases as the diaphragm goes down, which causes lower air pressure, which causes air to rush into the opening, which happens to be the mouth and the trachea. And so then whenever someone basically relaxes and this is kind of one of those autonomic things we can control, but we don't think about, right? We can stop breathing for a while. So we do have control of it. That's why they call it skeletal muscle for the diaphragm. Smooth muscle we cannot control. So the diaphragm is actually skeletal muscle. We thankfully have a autonomic ability. Our body keeps us breathing while we don't think about it. Because how would we sleep at night, right? How would you go to sleep if you had to actually remember to breathe? That wouldn't work. But the big thing to know is the diaphragm contracting increases chest volume, pressure goes down, air rushes in, and then whenever the diaphragm relaxes, it elongates again, so the air is kind of pushed outwardly. But the active process is the diaphragm going down. There are other accessory muscles of respiration, which we call those the external intercostal muscles. They're basically your baby-backed ribs. When you eat ribs, the muscles in between those ribs are intercostal muscles. And there are internal intercostal muscles, but the ones that are external are the ones that help open the chest up. These don't do much. You can't live with just those. If the diaphragm quits, you got to be in an iron lung machine to breathe for you, which they don't do those that often, but they used to for polio. Anyway, so that's our respiration. Expiration, here's a lot of language. I don't know. I don't think we're going to repeat. I think I showed you pretty much the picture. Yeah, let's kind of move on. You guys have the notes and you can read all these things, but basically, whenever it relaxes, it's going to go up and force air out. Here is, these are some good test questions, and really for just everybody's awareness of their lung ability. This is where it gets really neat in this chapter. We've looked at some anatomy. We kind of have a general idea. This is more like, hey, we're going to the lung clinic because we're worried about our lungs. And they're going to do some tests. Tidal volume, if you think about tides of the ocean, they come in and they go out, they come in and they go out. So that is our amount of air that we're doing when we're breathing normally, like right now. How many breaths per minute are we breathing in and out? That would be our rate. How big is the amount is the volume. Quite honestly, guys, there's a lot of vocab here, and there's a graph coming up that helps show us the difference. So I'm going to talk about the graph. I'm going to jump ahead, but basically all these terms I'm going to talk about. When we look at the graph, here's our graph. It has everything on there. So let's just kind of follow what's going on. The first thing to do is think about it. Over on the axis here, the left side, average lung volume in milliliters. It says the average human lung volume is 5,800 milliliters. I tend to like to round to make it easier to kind of remember, because I would never like try to trick you on a test. How much is it? Is it 5,600 or 5,700 or 5,800 or 5,900? I don't do that kind of stuff. I'd be aware of, I would try to memorize 5,800, or if we could just say 6 liters. Guys, I'm a little bigger than the average person. This is the average for everybody. When you look at these kind of numbers, they average everybody. So some of us in here in this room would be less, some would be more. But if you think about 3 2-liter soda pops, bottles of soda, right? That's 6 liters. Now, obviously, 0 down here. So let's look at these numbers. Why'd they put these different numbers? 0 to 1,200, if we follow it along, we call that the residual volume. You could basically say this is the air that you cannot breathe out. Right now, if I said, guys, I want you to breathe out as hard as you can, and you exhaled all the way, you would still have about 1,200 mils in your lungs. And this is actually what I was talking about. This will cause the lungs to float. Everybody's had a breath of air. They puffed up. They're gonna float. If we were to check, we're not going to be cutting our lungs up and putting them in water to see, but they would. So residual volume is an easy one to remember. Tidal volume, I honestly think that's an easy one to remember. How much do we, on average, breathe out and in every minute, or every breath? 500 mils. It's 500 milliliters, so half a liter. This would be resting tidal volume for the average person, 500 milliliters. And if we're resting and we tell somebody in a lab, we want you to breathe in as hard as you can. And we want to see how big your lungs are. And it's kind of a challenge. If you ever do a test like this, it's kind of fun. You're like, oh, I'm gonna just breathe in. I'm gonna have the record, I'm gonna be the record breaker. And you inhale and inhale and inhale, and you can't go any further. So the distance from, if we look, the top of the tidal volume and the top of what we can breathe in, the maximum breath in, this is our reserve volume that is related to inspiration. So they call it inspiratory reserve volume. I don't ask you how many mils that is, guys, because we get too many numbers, but just know that whatever you can breathe in above tidal volume is your inspiratory reserve. So what about if I ask you, hey, now that you've breathed in all the way, I want you to just breathe out all the way. Well, that distance would be the expiratory reserve volume. And if we add up these 3 things, basically what you can use, right? If you think about it, you can use this inspiratory reserve if you need it. Like if you start working out, running up a hill or whatever, you're going to start breathing in, you're going to do this. And you're also going to breathe out more to help you be able to exchange more air. You don't really notice breathing out more, but you do. But you definitely do this. It's very obvious that we breathe in more. So the vital life, when you say vital, it means like life force. Your life force that you can change is the vital capacity. That's the total amount of air in and out possible for you. And then the lung total capacity, of course, that's just everything. So a lot of times I'll ask a question like, what is vital capacity? Well, you would want to include three things. You know, tidal volume for sure, inspiratory and expiratory reserve. What if I said, hey, what is total lung capacity? Well, it's also got this residual volume. How many milliliters is tidal volume? 500. How many milliliters is the total lung? About 6 liters, 5,800, somewhere around there. So you can imagine as you age, somebody that just maybe breathed a lot of dust, you know, they worked at a rock quarry and they had a bunch of gravel dust in their lungs. That's one of the famous places for that. They start to get pulmonary fibrosis, which their lungs start to get non-elastic. They can't flex. It's not lung cancer, but it's the lungs are getting kind of stiff. You can imagine that they would go into the clinic and would have a lower amount for certain things. So this little graph was produced by somebody clamping their nose and blowing into a tube that measures the volume, and a computer reads it. We actually have some of these here at the school that are not this nice. They don't really work that good, and you have to worry about, you know, we don't do a lab in it, but you guys might take classes later. By the way, pulmonary therapist it's a very good job. Like, there are so many people that are having lung problems as we age. Even with smoking kind of being like less and less, people are trying to get away from smoking. That's kind of happening. So many people are aging up and lungs are getting older. And talking to people at the hospital, there are specialized people that just go around and take care of patients' lung treatments. And they get paid pretty good. And, you know, there are doctors that are called pulmonologists. They specifically deal with lungs. But this machine here, our book, I think, gives us the name of it somewhere. And I don't know where it is. I'll just tell you, it's called a spirometer. It's spelled S-P-I-R-O, spirometer, right? Spirometer. And like that measures your lung function, which is a really cool little test. Okay, so we're going to take a break for a second here. I'm going to go ahead and stop this recording. And if I can find it.